let's go ahead with presentation. Why do we need to do mediastinal staging in managing lung cancer? And first of all, what is the definition of early stage lung cancer? We do not have a clear-cut definition, but most of the papers include T1, T2, N0 to max N1 as a early stage lung cancer. So whenever we start management of lung cancer, we need a proper staging. Tissue diagnosis is first thing, then followed by PET CCT and MRI brain. But can we rely on PET CCT alone for mediastinal stage? We have already seen that in radiology workshop that PET CCT is not good enough for mediastinal staging. So if you see lung cancer that is only localized, that is only T1, T2, T3 kind of, has a 5-year survival of around 50%, but the moment disease goes to node, 5-year survival decreases by 50%. So that is why nodal staging is not only a very good prognostic indicator, but also it hints towards the treatment protocol that we need to subject the patient to. And on the right side, you can see a picture taken from CR database, which says that as the nodal stage increases, the median survival or 5-year survival significantly drops down. That is why most of the patients before planning treatment will need an invasive mediastinal staging. But whom can we avoid this? A peripheral T1, that is clinical T1, located in the peripheral part of lung, and N0 on PET CCT, we can avoid any sort of invasive mediastinal staging, and we can go ahead with the treatment protocol. Why PET is not good enough? Because we have seen that false positive rate is around 18% in our own series, and mostly that is because of infective etiologies and granulomatous disease. That is, 1 out of every 5 patients will be upstage if we depend only on the PET CCT. There are some factors which can lead to false negative rate also, that is shine through effect, or if there is node or primary which is not avid. So PET will not show any significant avidity in such cases. There are 2 types by which we can do invasive medial staging. Either it can be EBUS or mediastinoscopy. Both have got some theoretical advantages and disadvantages. EBUS obviously is less invasive. It can be done under conscious sedations. And so far it is recommended as an initial step. Rapid on-site examination can be done so that you can get the nodal stage at the same time. And it is associated with negligible complications. Whereas mediastinoscopy is a surgical procedure, required general anesthesia, and with literature, if we see literature, there is a complication rate of around 6%. Mostly it is recurrent laryngeal nerve palsy, and sometimes it is chyle leak. And also, if you see EBUS, the reach of EBUS is slightly more compared to mediastinoscopy. It can go to the hilar as well as interlobar nodes, whereas your mediastinoscopy is not able to reach. So less of a complication and wider reach of EBUS compared to mediastinoscopy. These are the papers, these are the old publications, prospective studies, single arm, which have shown that EBUS has got a good sensitivity for staging in lung cancer. If we see sensitivities, it ranges from around 80 to 88%, and mediastinoscopy is also nearby close, that is 88 to 85%. Accuracy is also almost the same, 90%, approx 90% with EBUS, and mediastinoscopy also close to 90%. But can we get these kind of results in our real world scenario also? If you see paper by Korean paper by Won, 90%, more than 90% of nodes that were sampled, they had done cell block, that is core biopsy also. They sampled every node which was more than 5 millimeters. So you to achieve that kind of sensitivity with EBUS, you need a good expertise. So it is an operator dependent with the learning curve. As the expertise increases, the sensitivity also increases. This is an Astor paper published in 2010, which says that if EBUS is negative and you do surgical staging, that is mediastinoscopy, your sensitivity of staging is going to increase. So based on this paper only, ESTS published its guideline. Go ahead with EBUS, but if EBUS is negative, confirm that with mediastinoscopy and then proceed for the treatment. But if you see today's scenario, EBUS has changed. There are a lot of modification and development in EBUS also. Expertise is also increasing. There is elastography and Doppler with the ultrasound. And there is a scoring system that depends upon the criteria of node, that is margin, size, your coagulation necrosis sign, central hilar sign, and according to that you can give a score to a node whether that is more likely to be a malignant and not. You can also decide the area of a node to be sampled based upon elastography and Doppler findings. So that is why EBUS, the sensitivity of EBUS is improving. And an important thing is that, as we have already mentioned, it has very little or almost no complications. So with so much of advancement, do we need to confirm our EBUS finding with mediastinoscopy? There was a meta-analysis by Bosimov in 2019 which says that if you add mediastinoscopy, there is only slightly increased in unforeseen N2, but there is no significant survival advantage that you are adding by adding another investigation, that is mediastinoscopy. Another randomized trial was published recently, that is Medias trial. I am not a great fan. I have not understood, I think, this trial very well. So what they did EBUS of all patients. If EBUS was negative, then they randomized a patient to surgical staging with mediastinoscopy followed by definitive surgery versus direct surgical management. What they found that upstaging was of around 8%. But according to this paper, that 8% jump over the EBUS was not considered as a significant. But I am a surgeon, I cannot still rule out mediastinoscopy completely based upon these, because it has got some significant advantages compared to EBUS. So if you see, sometimes nodes look small, but they may be infiltrating adjacent structure, which can be conclusively confirmed with mediastinoscopy. You do not have to, you can avoid unnecessary thoracotomy in such kind of cases. Left-sided tumor, if you want to clear 4L and 4R node, you have to go below the arch aorta. That is relatively difficult or near impossible to reach to 2L area. Either you do VATS, robotic, or thoracotomy approach. RLN palsy obviously is higher, but that is what you pay for a better clearance or oncological clearance for any procedure. So BEMLA still has got some upper hand or advantages compared to EBUS. Now, so whatever we have seen so far, if you do EBUS is negative, do mediastinoscopy, obviously sensitivity is going to improve, but still, even after all this, if you see, unforeseen N2 is still found in around 5 to 7% percentage of cases, and there are still few unnecessary thoracotomies. So how much, what is your cutoff? How much perfect is the perfect you need to say? But if you see, this is the paper published by two of the important authors who have done a lot of work in EBUS. In spite of so much of evidence, even now the uptake of invasive mediastinal staging is not that great. This is a paper from Denmark, and this here they have seen that in a general population or other hospital, the strictness to adhere to invasive mediastinal staging is only approximately 20%. So we have to balance our act. So we have two modalities, EBUS and mediastinoscopy, looking at the cost, infrastructures. Sometimes we may deviate from the routine protocol, that is EBUS is negative confirmed with mediastinoscopy. So what I think, if there is a high chances of node being positive, EBUS is good enough. But if the nodes are small, not avid, and you want to do, then mediastinoscopy is better, because you can get a proper clearance. Smaller nodes can also be removed, and sensitivity will be better in such cases. So to conclude, nodal status is significantly going to impact the prognosis as well as the treatment protocol. So you have to tailor your invasive mediastinal staging according to patient and the imaging finding. It is difficult to be perfect, but it is better to be wise. Thank you.
It's a nice presentation, Virendra. Very meticulous and crisp. Do you want to continue with your own lecture?
Yeah.
Okay. So we will move ahead with the management of early stage lung cancer session, and we'll go for the surgery for early stage lung cancer. And the speaker is Dr. Virendra itself.
So again, as I have told you in previous talk, that definition of early stage lung cancer is little bit not very clear. Most of the paper says T1, T2, N0, N1, but if you see ISLC paper, they say whatever is upfront resectable can be considered as early stage lung cancer, that is select stage 3A also. These are the points under which I am going to discuss the topic, that is surgery for early stage lung cancer. First of all, why do we need to operate early stage lung cancer? So this is a paper long back published in NEJM, that is 2006, Early Lung Cancer Action Project. This was a single arm screening trial. They found that if you detect a cancer in early stage, that is stage 1, and you operate within 1 month of diagnosis, the 10-year survival rate is 92%. Again, this is a picture taken from AJCC. If you see pathological T1 to TC, 5-year survival is more than 80%. So these are few papers, but they give a significant and solid proof that if you operate early stage lung cancer, the survival is excellent. So similar is the statement made by most of the recommendation, that is NCCN or ESMO. They say that surgery is preferred if patient is fit and in early stage lung cancer. Now we have decided that patient should be operated. What is the approach? Now we have to either minimally invasive or it is a thoracotomy and surgery. Minimally invasive again can be either video assisted or it can be robotic. The pictures itself are self-explanatory. Right hand side it is uniportal VATS, small 3 to 4 centimeters incision, no rib spreading. Whereas on the left side you have a thoracotomy where you cut the muscle, you put a rib spreader, and sometimes there is a rib fracture and injury to intercostal nerve. So obviously the post-operative outcome we can understand from the picture itself. The proposed benefit of minimally invasive surgery is that it is associated with less pain, faster recovery, there are less post-operative complication, and better quality return to function is there with the minimally invasive compared to open surgery, and there is an equivalent oncological outcome. We have enough evidence to support this. 2 randomized control trial, one from 2016 and another from 2018. Both of these papers say that immediate post-operative outcome is good with the minimally invasive surgery compared to thoracotomy. This is a recent RCT published in NEJM in 2022, which says that physical quality is better if patient has undergone minimally invasive, that is VATS surgery, for approximately 6 months post-operatively. The analgesia requirement and the pain score both are less if patient has undergone VATS surgery compared to thoracotomy. And same is the statement made by Global Trend. Society of Thoracic Surgery, in this paper they have said that more than 50% of lung resection nowadays are performed with VATS approach. And there is another kid in the block that is robotic, and the uptake of robotic is also increasing compared to thoracotomy. Now we have decided that we need to operate. We have discussed about the approach also. Now what is the ideal extent of surgery for a early stage lung cancer? Now to operate, we need to take care of T as well as N stage. This is an old randomized control trial, published landmark paper published in 1995 by lung cancer study group. They randomized patients of T1 N0 into sublobar resection and lobectomy. What they found that if the patient has undergone sublobar resection, there is increased chances of local recurrence and there is a poor overall survival. But there are significant drawbacks of this paper. The proper PET CT or invasive mediastinal staging uptake was not that great at that time. Now we have 2 important randomized control trial to challenge this statement made by a lung cancer study group in 1995. Till now, lobectomy was considered standard, but there are 2 RCTs. One is from Japan, that is JACOG by Asamura, which says that if you do sublobar resection for a clinical T1B, that is less than or equal to 2 centimeter peripheral tumor N0 disease, the 5-year survival of segmentectomy was 94%, which was slightly higher compared to lobectomy group. But obviously there were more air leak and higher local recurrence in segmentectomy group compared to lobectomy. And same is the outcome of a CalGB trial recently published. Here they have again randomized patient of same subset of patient, that is less than or equal to 2 centimeter peripheral N0 disease. They randomized into sublobar to lobectomy. Here around 60% of cases had undergone wedge resection. In JACOG trial it was anatomical segmentectomy, whereas here it was non-anatomical resection, that is wedge also. And 60% of patients, 59.1% of patients had undergone sublobar resection, that is wedge resection. Even they found that DFS and OS of sublobar compared to lobectomy is similar. So sublobar resection, that is segmentectomy or wedge, can be done, but there is a selective indication, tumors which are less than or equal to 2 centimeter N0. But all segments are not simple. Segment 1, segment 6, lingula, middle lobe, these are easier segment, but the basal segments are difficult, so it is a challenging procedure to perform. Now this was all about T. Now coming to N. Now there are two things, either you can sample nodes or you can systematically clear nodal stations depending upon the site of disease. This is a meta-analysis of important 5 RCTs which says that sampling or systematic nodal clearance, there is no significant difference in the complication, but prognostic information that you get with systematic clearance is more compared to sampling. That is why systematic nodal clearance is preferred. We have operated also patient, but what is the post-operative outcome? These are the two important randomized control trial. One is from 2011, another one is from 2022. Both had more than 1,000 patients. In ECOSOC trial, most of the patient had undergone thoracotomy. They found that morbidity, post-operative, all kind of morbidity is around 38 with mortality of 1.37. Whereas on right hand side, JCOG, most of the patient, that is 90% of patient had undergone minimally invasive. They found that morbidity is 26 with mortality of 0%. What I want to say that approach doesn't matter. If you operate patient, post-operative recovery, morbidity, mortality is acceptable with both minimally invasive or thoracotomy approach. This is our own data from 2017 to 21. We have done more than 100 video assisted surgery with median length of hospital stay 4 days, post-operative mortality of 0.9 and major morbidity of 13.2%. Now still whatever you say, but there is still unmet need. As the stage advances, the outcome worsens. And systemic therapy is obviously there to improve survival. With LACE meta-analysis, what we have seen that there is a 5-year survival advantage of adding systemic therapy. But we need to push more and improve the outcome of a even early stage further. So there are a lot of randomized trial or evidence that we have regarding targeted and immunotherapy to improve survival. So at the end, I would like to conclude by saying that surgery is a standard of care for early stage lung cancer. Minimally invasive approach, that is VAT, should be preferred. Lobectomy is still a standard. Segmentectomy can be done, but selective indication, and it needs little bit of expertise. It is a complex resection. Systematic mediastinal nodal clearance will give you better prognostic information with no significant complications. Obviously, unmet need persists, and we need to push ourselves more to improve survival of such cases. Thank you.